going to do is I'm going to turn it over to Lamont Johnson. Lamont is our president for currently, since Anna Marshall is on maternity leave, and then we'll be taking over in an official capacity in like a week. So Lamont, are you, I see you down there. Let's see here, let's spotlight your video and let you talk.
Thanks, Brett. Hopefully you guys can hear me now. I've definitely had some challenges getting into the meeting today, but hello, my name is Lamont Johnson. I'm the current CoreNet Global Carolinas Chapter Vice President and incoming president for the new year starting April 1st. Thank you all for joining this event today, and thank you to all our sponsors for our Carolinas chapter. And a special thanks goes out to Alfred Williams for sponsoring this event. From a CoreNet Global standpoint, just to tell you a little bit about the organization, CoreNet Global is a nonprofit organization headquartered in Atlanta, Georgia, representing more than 11,000 members in 50 countries with strategic responsibilities for real estate assets of large corporations. The organization's mission is to advance the practice of corporate real estate through professional development opportunities, publications, research, conferences, and also designations through a network of 46 local chapters throughout our organizations. The Carolinas chapters, of course, is one of those 46 chapters. We like to say the best chapter. Our CoreNet Carolinas mission is to deliver value and connect people to enhance and develop the world of corporate real estate. For those who are on the meeting today that are already members, we thank you. But for those who are not, we encourage you to go ahead and renew your membership. Or if you would like to join, there's opportunity for you to join today in this great chapter. From an event standpoint, we have another event coming up on April the 22nd called Gaming is Serious Business. So this is an event around gaming and some of the corporate real estate around some of the gaming organizations that we have in the Triad area. Also, so some other events we have this year, we have our numerous programming and network events in both the Triangle and Charlotte area, as well as our South Carolina market. We have the golf tournament that's coming up. Our annual golf and tech symposium is coming up, and our annual core awards will be coming up as well. So a lot of great events coming up for the CoreNet organization, give you opportunity to engage with us in these events, excuse me, in the future. And if you enjoy what you're seeing today and you're not a member or you're not a part of the organization, please reach out to Brett and he can help you connect with the right person. Again, we want to thank Alfred Williams for sponsoring, and also I'd like to introduce Amber Brown, who is the regional president for the Charlotte Triad and South Carolina for Alfred Williams, and also a member of our CoreNet Carolinas board. So Amber, we'll turn it over to you.
Thank you very much. So I just want to say thank you for the opportunity to present the session today. As Lamont said, I'm Amber Brown. I'm the regional president for Alfred Williams and Company for Charlotte, South Carolina, and the Triad. Alfred Williams and Company is the Herman Miller dealer for North Carolina, South Carolina, and Tennessee. And we're a full service provider of workplace solutions for government, commercial, healthcare, and education. Obviously, the last year has been an interesting time for all of us. And while somewhat uncertain, sometimes uncertainty brings a lot of innovation. And I think one of the interesting things for us as a company and for all of us in CoreNet is that the ideas and the innovation that could come out of this last year are really interesting. And when it comes to how that applies in the workplace, we are spending a lot of energy having those conversations and thinking about what could be different. How can we create meaningful environments and meaningful engagements for our employees, regardless of what the office or the workplace looks like, because it could look very different, and we find that to be very exciting. I'm also very excited to introduce Dr. Tilson today. As you know, we did have a little bit of a change, although I know that the professionals within our state and the healthcare professionals spend a lot of time talking about what the future looks like for us and how we do get back into the office and how we do get back into our workplaces. So I'm very excited to introduce Dr. Tilson, and there she is. She has generously has stepped in for a group that I know has a lot of questions and is also really interested in the guidance that you can provide to us as the real estate professionals on how we can return to the office. So I know I don't want to take up more time because I want to give her plenty of time to share content and then also to talk about questions at the end. So Dr. Tilson, thank you for joining us, and I'm going to turn it over to you.
Great, thank you. And I'm happy to be here. Always happy to pinch it for the secretary. And yeah, I'm sorry for the last minute change, but happy to be here. Hold on, let me squeeze my camera to make it a little bit sharper. There we go. Yeah, so happy to. I will go ahead and share my screen. I'll run through some of the slides for you, but then make sure we have time for Q&A. I'm happy to do that as well. So, great. Okay, are you seeing my screen and the slides? Yep, okay, I'm seeing some nods. Perfect. Wonderful. Let me see. Let me start the show instead of seeing all of those. Perfect. Okay, great. So just a bit of an overview of our overall COVID-19 update, and then we'll spend some time in vaccines because that is obviously what is going on very rapidly now. And really, I think will be that path to getting people back into the office, getting life back to a little bit more normal. Some of the things that you all were talking about, I think there are an enormous amount of really important preventive strategies that we've all been using throughout the course of the COVID pandemic, and then vaccines being a really, really important layer to that. So we'll spend some time on that as well. So just doing some big buckets of important elements of our COVID response. One, we have had 2 waves of our COVID in our state, but we've managed to avoid major surges that have really expanded or eclipsed our healthcare capacity, which really was our goal. So we had a bump in the summer, we had a huge surge over the holidays, and we are coming down from that. We may, in the future, continue to have some surges. We know that variants are on the horizon, and envisioning that we will be having some bumps as we go forward, but we have managed to not have a huge surge that has eclipsed our healthcare capacity, which was really one of our main goals. We've always tried to use data guiding our path forward. A little bit of a challenge when you have a novel virus that had not been on the earth before December of 2019. Having a data-driven approach when you didn't have always the science behind you was a bit of a challenge, but as we were learning more, as we were getting the data more, we tried to use that as much as possible, and I'll make sure that you see some of our data and hope that you follow along on our data dashboard. We've tried to be as very transparent as possible. And we've used that data to really then drive some of our policy, thinking through mask mandates, really a measured approach to closing and reopening. So we've really tried to use that data. From the beginning, we've also tried to have equity built into every aspect of our response. We know that a historically marginalized population have really bared a disproportionate burden of the pandemic for a whole variety of reasons. We've tried to be responsive to that as part of our response, and responsive to that as part of our vaccination strategy as well. And we've really had to build new capabilities, new systems, either IT systems or reporting systems, all sorts of capabilities we've had to stand up pretty quickly as part of our new response. And having a public health infrastructure be really not well funded for many, many, many years, we had to on the fly build a bunch of infrastructure that really wasn't there. And so we are excited about these new capabilities and excited about moving forward to be able to leverage the infrastructure that we've been building. So part of our data-driven approach, and again, a piece of this and a piece of our values are transparency. I hope many of you look at our dashboard daily. We have lots of data up there. On the far left, or on the left side, is some of our key metrics that we have been using to really guide our policy decisions, looking at our total cases, looking at our percent positivity, looking at our hospitalizations, looking at people coming to the emergency room. And then we also have our county alert system that not only looks at statewide levels, but also drills down to our county and gives us an idea of what's going on at our county level. On the top here, you'll see this little bump here. That was the surge we had in the summer, and then this big peak is the surge that we had over the holidays, and we are coming down, thankfully, from that. On the right-hand side, this is a subset of some of the data that we have on our vaccinations. We are tracking how many doses that we're giving, how quickly we're administering those first doses. We have it down at the county level, and we also are looking at, on the top here, you'll see the percent of the population that has been vaccinated, either partially or fully. And then we also have a lot of our equity data on our vaccine dashboard as well, and looking at of all those vaccines, to whom are they going, and really wanting to be sure that we are vaccinating our population at least proportionate to the to that population in our state. So we still have some work to do in terms of our equity, just taking, for example, our Black or African American folks in North Carolina. They make up 23% of our North Carolinians, but to date have only received almost 17% of the vaccination. So we know we have work to do. This bar chart you'll see week over week is the progress that we're making in more equitable distribution of the vaccine. On the far left, the purple line are our white North Carolinians, and you can see in the beginning disproportionate amount of vaccine was going to our white population. As we've moved from left to right, you can see a better proportionality of those vaccines, more equitable distribution of the vaccine. So still more work to do, but we're making progress there. So let's talk a little bit more about vaccines. We are very excited. I will say I am exceedingly personally excited to have vaccines. This really is our path out of this pandemic that has affected all of us in so many different ways. Some really nice news about our vaccines, although the COVID-specific vaccine is new, or are new, I should say, because we have multiple. They really have been based on similar methodologies for vaccines for different infectious diseases, so we had a great head start and really, really good science that could be leveraged for this specific vaccine. And then with the strength of the clinical trials that really had 10 times the normal enrollment of a clinical trial, we have lots of data on these vaccines being safe and effective. One piece, and this is really for all vaccines as well, but just there's a lot of misinformation about vaccine, but one really important piece is that you cannot get COVID-19 from the vaccine. None of these are live virus vaccines, and you cannot get COVID from the vaccine. So our supplies have been limited, but the good news is that our supplies are expanding, which is really nice, and I'll talk about moving through the groups, that we've been able to move through our priority groups actually pretty quickly, a little bit more quickly than we had maybe anticipated, because the supplies of our vaccines are increasing. So that's really good, especially when we think about being able to more fully offer it to a lot of our employees, a lot of our workforce. That is going to be easier and easier as we move forward, which is I'm very excited about. As I alluded to, we have currently 3 vaccines that are authorized by the FDA and that have been recommended by the CDC, and then we have them in the state. We have the Johnson & Johnson, the Moderna, and the Pfizer. The Moderna and the Pfizer are the 2-dose vaccines, and really, really important that people get that second dose and get that second dose on time. And then the Johnson & Johnson, the beauty of the Johnson & Johnson is that it's only a 1-dose vaccine, which is really nice and much more convenient for folks. And we've actually heard from a lot of our people that they have been actually waiting for the 1-dose vaccine, that it means less time away from work, either to get the vaccine or if they might have some side effects for the day or two after, less time away from work. So most people say, I'll get whatever vaccine I can as long as it's safe and effective, which they all are, but if anybody actually expresses a preference, it has been for the J&J because of that beauty, Johnson & Johnson, I apologize, for that beauty of that 1 dose. So we're really excited about that. And we did have to stand up a brand new data system for our vaccinations, which we call CVMS. You may have heard that. It stands for our COVID Vaccine Management System. So we have that up there, and especially for those 2 doses, so we're sure that people get that second dose on time. Next slide. Great, and so we have vaccines in the state, our supplies are increasing, so we want to be sure people know how and where they can get a vaccine. So we have stood up multiple tools to help our people navigate to vaccines. And you can find all of that on our website, the Your Spot, Your Shot, nc.gov. That's a portion of our website that's dedicated to our vaccines. We also have a call center that is bilingual. We have, as part of our tools, people can figure out where they fit in their priority group, although thankfully that is getting less and less important, and I'll talk through as we move forward. And then you can also find, you can navigate to a COVID vaccination provider depending on where you are. We have them all listed there, and you can find out who is a vaccinating provider in your area. And just last week, we also launched the ability that if a provider wants to have online appointment capability, they can do that as well. So you can navigate through a website to that provider, and if that provider has opted into doing online appointments, you can do that whole appointment navigation and appointing through that site. So I alluded to, or not alluded to, but as I actually very intentionally wanted to say, that equity has been exceedingly important, not just through a whole response, but also through our vaccination efforts. And so we've really done a lot of work and need to continue to do a lot of work in partnering with our communities and with trusted voices and trusted places in our communities to be sure that this vaccine is trusted and is accessible to everybody. So really working with those trusted partnerships, our faith communities, our schools, those community-based organizations that are trusted and are located in places that are accessible and comfortable for people. We've tried to address different barriers for folks. For example, we use some of our COVID dollars to fund our transportation vendors so that people can get rides to vaccine sites to make that easier. We've made it very clear to our vaccinating providers that we expect them to be vaccinating people proportionate to that population in their communities. And we're leveraging different workforces. For example, our community health workers that really can do that outreach for us and can help people be able to get appointments and navigate to places. So we've done a lot of work. We still have a huge amount of work. We will be launching next week our Healthier Together initiative, which is a very intentional framework that we are building across the state to really be sure we're achieving equity and doing so in partnership with people on the ground that are those trusted voices and who really understand the barriers far more than we sometimes do sitting in Raleigh. And this is another piece of our data. Again, I showed you some of our vaccine data looking at statewide, but we also are tracking, especially around our racial and ethnic lines, how we're doing with vaccine, where are our gaps, how can we hold ourselves and our providers accountable, and then also how do we bridge those partnerships to make sure we're equitable in that vaccine distribution. And so you can see another piece of the data that we have on our dashboard. And please follow along, and we'll also have this at the county level as well. To a certain extent, we want to make sure we're never breaching privacy, and if a count is too low at a county level, we are suppressing that, but as much as possible we have that, so you can also see how we're doing in your communities, and then how you can help in your communities as well. Okay, as I alluded to, and probably you all know, we have these prioritization phases. These have been really more important in the beginning when we had very, very limited supply. They're getting less and less important as we're moving forward, which is good and where we want to be. But we are currently in this first part of Group 4. And so this is anybody, so let me take a step back and say to this date, any of our healthcare workers, people in long-term care, are eligible, anybody 65 and over eligible, anybody who's a frontline essential worker, and I'll just, the next slide defines what that is, are all been eligible, and then as we've opened up to the first part of our Group 4, which is in anybody with a high-risk medical condition, as well as some people in high-risk congregate settings, so people in homeless shelters or people who are incarcerated. Then the second part of Group 4 will be broader, will be other essential workers. I'll talk about this a little bit, and then everybody. And we want to get to the everybody as quickly as possible, and I will talk through a couple dates. A little bit about Group 3. Group 3 are what are termed our frontline essential workers. And basically the intentionality of this group is people who have to do their work in person and are in these sectors that they draw from that CISO sector, but these sectors of essential workers who have to do their work in person. And so, for example, things like here's our teachers, our child care, our staff, our first responders, EMS, law enforcement, our people who are doing abuse and neglect, our folks in agriculture, our meat packers, our food processors, migrant farm workers, these types of people who have to do their work in person. And to be perfectly honest, these are the people for whom we saw a lot of the COVID cases and clusters and outbreaks because they could not social distance. Social distancing or working remotely really is a luxury for some of us. And so really being sure we're getting at those people who have to do their work in person. It also has a pretty disproportionate representation of people from a historically marginalized population, so that helps with our equity. And also in general has a group that has a higher proportion of people with high-risk medical conditions. So it's a really important group for us to be working through. And then group 4 that we're in now, again, anybody regardless of age, who has a high-risk medical condition as defined by the CDC, and you can see those categories. It's pretty broad, and also some folks in those high-risk congregate settings. No later than, and we're actually hopeful that we can move more quickly on these dates, but no later than April 7th, we'll be able to add other essential workers. And then maybe you've all heard, but the president has a goal to be sure we can open to all people before May 1st. That would be our group 5. I think we are on track, and our goal is to be able to open to group 5 before May 1st. So we're not that far away from everybody, and we're going to move as quickly as possible. And this is my last slide, so I think we'll have lots of time for questions and conversations, which is the fun part. But as you all are employers and thinking through either how do I get vaccine for myself or how do I get vaccine for my employees, there are a couple different ways, and I think those will be applicable depending upon the nature of your business, the size of your business, the robustness of your business. But we have this gradation of how employees can help their employees get vaccinated. On the far left is the most sophisticated and the most turnkey solution. And so we do have employers, big employers that have on-site occupational health. Those occupational health can actually become a COVID vaccinator themselves. They can get enrolled in the federal program. They have all of the requirements to do that, to be able to receive vaccine, to store vaccine, to administer vaccine, to record vaccine, that really acts like that healthcare provider for that employer. And we have some very big, very big industries that have that on-site occupational health, and they can just do it all turnkey, which is great. On the far right, are really for some of our smaller employees where they don't have that on-site occupational health and maybe not that many employees. And so for them, the solution may be, the easiest solution may be just make sure you know how your employees can navigate through that Find My Spot site that I alluded to, that they can figure out, know that they're eligible, and then they can, on that map, figure out where they have vaccine available for them. Maybe they can make an online appointment if that provider has already has that capability, and they can navigate the system like everybody else, but your role as an employer is to know, A, you're eligible, and B, provide information about that it's safe and effective. And maybe your role may be also making sure that you're giving people paid time off to actually get vaccinated, and then maybe considering paid time off a day or two after the vaccination in case they have some of that temporary side effects. So you can do those things to facilitate your employees, encourage and facilitate your employees from getting vaccinated, getting vaccinated. And then the middle two options, and again, this kind of depends probably on how big you are. The bigger organizations are doing a fair amount of matchmaking, and so we are matchmaking some of our employers with vaccinating providers in their area, and that may be a local health department, it may be a hospital, it may be a federally qualified health center, it may be a pharmacy. We have a lot more of enrolled vaccinating providers, and we're doing matchmaking that we have a vaccinating provider that says, ooh, I have a big chunk of vaccine. We match them with an employer to say, I have a bunch of employees, and then we can do matchmaking. And sometimes that matchmaking may be that vaccinating provider could come on site. That really is a little bit more applicable if you're a large organization. It's hard for a vaccinating provider to do a lot of that for smaller. Or it may be then that the vaccinating provider says, great, I'll set aside Tuesday afternoon, and we can appoint your employees there to have a little bit more of a tighter matchmaking. So there's a pretty broad spectrum of how this could work. And we have employee guidance. I'm happy to share that link with you all in thinking through these different possibilities. All right, I think that's it. And so it looks like we have some lots of time for questions, and so fire away, and I'm happy to answer as best I can what your questions are.
Well, thank you, Dr. Tilson. I will be reading through the chat and sending any questions, and I've got a couple as well, if we don't get enough. So from Steve, what does the end game for this pandemic look like? Do the cases just drop so low that people don't think there is any threat, or do we return to normalcy?
Yeah, that's a great question, and boy, I wish I knew the answer to that one, right? I think we all wish we knew the
Dr.
answer.
Tilson, do you mind to stop sharing your screen?
Oh,
there we
always.
go. I can do it actually. So there you go.
Oh, okay, great. Someone was ahead of me. Yeah, it's a great question. I wish I knew it, right? We all want to have the crystal ball, but with a novel pandemic and a novel virus, it's always hard to be completely definitive in my crystal ball. But I'll tell you what I think is going to happen. I think that this virus is going to continue to circulate. It'll probably just become one of our routine circulating viruses, much like for you, those of you who remember in 2009 when we had the H1N1 pandemic. That was a flu strain. It was a big deal in the beginning because just like this one, nobody had immunity, and so then the rate of transmission and the rate of spread was very quick. Then we got the vaccine, and then some people had immunity, and so now it is actually still circulating. In the flu this year was H1N1, so it's still circulating, but it doesn't cause the havoc and just the incredible disruption of our society because people have had enough immunity in different ways. That's what I think is going to happen with this one. We're going to build immunity either by the natural infection and much more protective by the vaccine. So this virus is going to keep spreading, but it's not going to cause the havoc in our society as it has. And we'll see it circulate with we have other coronaviruses that circulate with our regular cold and flu. So I think it'll keep circulating. I think it will, I call it undulations of decreasing amplitude, where I think we'll see these kind of peaks, but it'll dampen and dampen. The more people we get vaccinated, it'll dampen and dampen. So I think we'll be able to get back to normal in terms of not societal disruption, but this isn't going to go away. And I wonder, as we think about what does flu and cold season look like for us, when we look at our flu data, we've had almost no flu in North Carolina this year. It was amazing because of all the preventive strategies that you all have put in place for COVID. It's great with other respiratory viruses. So I think what I would love is that we go into flu and cold season, we bring these more preventive strategies more into bear. We can keep it all dampened and move forward. So it's not going to be we're done with COVID. It's just that it's a place that we can handle it as a society, and we'll have to think about how much we need to turn up or turn down those preventive strategies depending on how much it's taken hold.
Great. Thank you. We've got about 3 questions around that varied on this, so I'm going to try to combine them together. They all are in regards to returning back to the office, which is pretty common for a group like this to be asking something like that. With vaccine distribution percentage and going back toward the office, what does a safe distance look like when you're going back to the office? And are you able to sort of separate the people that, can you separate people that have vaccinated and some that haven't vaccinated? How does that look like when you go back into the office environment?
Yeah, so, there'll be a devil in a million different details. So I think let's talk through principles, and then you can think about how that is applying in your specific thing. So principle number 1, absolutely encourage your employees to get vaccinated. That's going to be one of the most important things. So making sure that they have that information, that they know about the vaccine, they know it's safe, they know it's effective, you're facilitating them getting vaccinated. The more of your workforce that can get vaccinated, the better. I think from an employee standpoint, it's going to be, you're going to have to think through a lot of privacy and whether and asking your employees if they've been vaccinated or not. There's privacy issues around that. That's personal health information. That's going to be a thing that is going to be pretty difficult for you and probably not legal for you to ask people if they've been vaccinated or not because it is our PHI. So for you to be able to say, I'm going to separate people if they've been vaccinated or not, that's going to be dependent upon you knowing if they're vaccinated or not, and there's some dicey things in there. But the best thing to do is make sure everybody is, as many people is vaccinated as much as possible. What we're doing as a state government is that what we are saying is that once we have enough vaccine and we know that the vast majority of people who want to be vaccinated have the ability to be vaccinated, then we're going to have people coming back to work. I think it will be good as much as possible if we can, the more the distance of people, the better. We are getting more and more information that 3 feet of distance probably is protective, probably not as protective as 6 feet, but 3 feet is protective. Still, the hand washing is going to be really important, and I think for the time being, still wearing masks, especially when we're inside, is still going to be important. But I think we'll be able to lighten up some of those pieces. And then all of the, the environmental cleaning too. Although really it's the person-to-person spread that's more important, but the environmental cleaning still adds a layer of protection.
Thank you. The questions are rolling in now. Sean O'Neill asked, how does North Carolina define herd immunity, and what will guidelines and guidance look like once it's achieved?
Yeah, I went to college with a Sean O'Neill. It's probably a very common name, but in case I went to college with you, Sean. Hey. Yeah, so everybody wants that magic number. What's herd immunity? So again, this is a novel virus, and we don't know what the magic herd immunity is for this virus. Each virus has its own level of herd immunity, really depending on its transmissibility. And we know this virus, as the variants are coming in, they each have different levels of transmissibility. So I cannot tell you this specific percentage is giving me that herd immunity. So, for example, measles, which is the most transmissible virus, needs about 98% of the population immune to achieve herd immunity, whereas something like other infections that are less, it's like 80%. So I can't tell you the magic number, but what I can tell you is the more people that get vaccinated, the more of the dead ends for each of those viruses, the better. And we're already seeing that. We are already seeing, looking at our data for our 65-year-olds, which obviously was a big portion of our initial priority, we're seeing drops, quite precipitous drops in our 65-year-olds in those cases. So that's all a good thing, but I can't give you a magic number, but what I can tell you is the more people vaccinated, the less the virus will spread, and the more we'll see those rates drop.
All right, I'm just going to go down the list. What does DHHS think is the likelihood that variants emerge later this year and cause us to go through another round of isolating at home where possible until vaccines can be modified, tested, and produced? And that's from Erin Kirtley.
Yeah, so variants are here in North Carolina. We know that. Variants are here. And so March has really been, in my mind, a pretty crucial month, because it's kind of a race against the variants. Viruses always have variants. This is what they do. We know they're going to do it. They absolutely will continue to have variants, and we know they're in North Carolina. What we want to do is kind of, for right now, the vaccines still seem to be effective, at least for that B117, which is the UK variant, which was the one that seems to be the most transmissible. So the more vaccines we can get into people right now, the more that we will stop that big surge of the variants. But the variants are going to be there, absolutely. We're going to probably then, that's what I'm talking about, that this is still going to circulate, or these are still going to circulate, and we might end up having to then adjust vaccines as we go forward, maybe do boosters as we go forward, depending on the strain. Same thing like we do with flu. You may not know, but the flu vaccine that I hope you get every year, most of them are what we call a quadrivalent. You actually get vaccinated for 4 strains of the flu every year. So I think that'll probably be what we do as well. And this way, I think we'll see some of these bumps as we go forward, as different strains are taking hold. But the best thing we can do right now is get as many people vaccinated right now to have as many of those dead ends for that virus, so that those ones that have variants, they won't have a place to go. But that's why I said these viruses will be with us and will continue to circulate with those different variants.
All right, I'm going to try to combine Jean Marie and Rebecca's questions. Now that people are vaccinated, is there any recent information on the likelihood that vaccinated people can unknowingly transfer the virus? And how do we know that it's safe when there's no long-term studies?
Yeah, so the first one first. The clinical trials were not set up to answer that specific question, that can vaccinated people spread, especially asymptomatic vaccinated people, spread virus. That was not what the question for the clinical trials were. The question for the clinical trials were, will this prevent people from getting really, really sick and dying? However, some of the data, they've been able to look for those clinical trials, and now new trials are looking specifically at that question of, will it prevent you from spreading asymptomatically? So those trials are going on now, those studies are going on. The data that I have been seeing from those look like, yes, yay, maybe 70% or maybe even more protective of preventing transmission. So that's really, really, really good. So I think that it will end up being that, yes, getting vaccinated does decrease that asymptomatic spread. It just wasn't the question that was specifically answered in those clinical trials. But the data that's coming out is more positive of that, which is why the CDC recommendations now are that if you are fully vaccinated, if you are amongst fully vaccinated people, then you don't need to do that mask wearing, the physical distance, because the risk really seems to be greatly reduced. So the more and more fully vaccinated people, yay, the less that we have to really worry about that asymptomatic transmission. In terms of safety and efficacy, so first thing, as I said, that the methodologies for these vaccines, we've had multiple years of using that same carriage of the vaccine. We just have the information for the specific vaccine is new. So we have lots of track record of the safety and efficacy of again, either the mRNA technology or the viral vector technology. So we have that. And then there is the clinical trials will have ongoing clinical trials, and we'll have at least 2-year follow-up, if not more, of these clinical trials to add more of that safety and efficacy data. So I think the person is right. For this specific vaccine, we don't have that long-term safety, but for these types of vaccines, we have lots of history of safety, and more data will be gathered as we go forward.
Great, thank you. It's 1 o'clock, so I'm gonna try to fit this in real quick. Dr. Chelsea, thank you. Trip asked, why do we never hear about those that have recovered and their immunity as an effective way to get herd immunity? Should those that have had COVID and had antibodies get the vaccine as well?
Let's see, so a couple different things. One, we do have on our data dashboard the number of recovered, but it's an estimate. It's not a hard data point that we can point to. We have an estimate, so we have them up there. The second is we don't know if someone has a natural infection. We do not know how long that natural immunity will last, and we do know that people can get reinfection. And with the threat of, well, as the evolution of the variants, we also know people will be able to get reinfected with the variants. So relying on that quote-unquote herd immunity from natural infection is just not a good thing to do, because again, we don't know how long that natural immunity will last. The other thing is, and again, we don't know what the herd immunity would be, but for most viruses, it's north of 75%. If we allowed 75% of our population to get it infected, I say that the path to natural herd immunity is through a lot of graves and graveyards, because so many people would die and get very sick if we relied on that natural immunity. We estimate that about 2.5 million people in North Carolina maybe have had that natural infection, but to get that potential herd immunity, that would mean about 8 million people would have to have that natural infection, and that would just be intolerable from a death and disability. So whatever herd immunity or population protection we were going to get, it's through vaccines, not through natural infection. And the answer is yes. If you've had the infection, yes, you should still get the vaccine.
Great, thank you. And we're coming up on time. I'm going to ask one more question that I saw before, and then we'll have to answer some of these other questions that are being asked as we chat together. The last one from Rebecca was, most research says this vaccine only lasts 6 months. Will everyone have to get vaccinated again?
So again, the research, if you just think about that, it's because they have not had the time to do the follow-up, because the vaccines, thinking about the path of the clinical trials and how long we've had the vaccine. So it's not that the research says that immunity only lasts 6 months. It's just that we only have data to show that the vaccine is effective for at least 6 months. And as we do more and more, and we have more time that people have had the vaccine, we'll continue to assess that data and see how long it will protect. So that is not, the research doesn't say it only lasts 6 months. The research said, hey, for at least 6 months, we know that it is effective. And actually, I saw some data that probably at least 2 years. So just remember, it is the time that we've had with this specific vaccine. It just limits what we can say for sure, but it's all intentions and all indications are that this will be a good lasting vaccine.
Great. Well, thank you, Dr. Tilson. This has been incredibly informative and helpful. And we appreciate your time in hopping on with us and sharing. And also, one more time, thank you, Alfred Williams and Company, for sponsoring the event. We really appreciate it, and thank you all. Like I said at the beginning, what we have now from 1 to 1:30 is the opportunity to stay together and chat through this. We're all learning as we go along through this together. So if you're interested in staying on and sort of having a networking, more informative discussion, please stay on. For those that are going to hop off, thank you for attending the CoreNet event. We really appreciate it, and we hope to see you at future events in the next couple months, hopefully in person at some point.